The coin hit the desk at 0340 hours. It made almost no sound, a soft, deliberate click of metal on laminate. But in the silence of a cardiac ICU at that hour, with the monitors humming their low, arrhythmic chorus and the overhead lights dialed down to their overnight setting, it was loud enough to turn heads. The man who placed it was still in his flight suit. He had not changed. He had not showered. He smelled like aviation fuel and cold air and the specific metallic aftermath of a night that had gone badly wrong at altitude. He was a warrant officer, CW4 by the insignia, and he had the kind of face that has been outdoors in bad weather for so long that it no longer registers weather as a variable. He did not go to the charge desk. He did not ask for the attending. He did not speak to the unit secretary or the resident on call, or the man in the expensive Oxford shirt, standing near the nurse's station, holding a tablet with a rigid posture of someone who expects to be consulted about everything. He walked directly to the nurse charting in the corner bay. He set the coin down in front of her. She looked at it. She looked at him. "Iron side," he said. That was all. She picked up the coin. She turned it once in her fingers. She set it back down next to her keyboard and went back to her charting. The warrant officer nodded once, the nod of a man whose business is finished, and walked back toward the elevator. In the hallway, Dr. Elliot Graves watched him go. The tablet in his hand had gone dark. The screen had timed out somewhere in the last 90 seconds, while he was standing perfectly still, and he had not noticed. But we're getting ahead of ourselves. Let me tell you about the 12 hours that preceded that coin. The cardiac hospital at Houston Methodist West is not the kind of place that gets travel nurses from staffing agencies. It is the kind of place that recruits. It is the kind of place with a donor wall in the lobby and a dedicated parking structure and a cardiac catheterization suite that a regional magazine once called the finest west of the Texas Medical Center. The nursing staff is credentialed, experienced, and deeply aware of the hospital's reputation, which they protect the way people protect things they have earned. Marin arrived on a Tuesday in November. She had a rolling duffel, a backpack, and a stethoscope that had been resold. If stethoscopes could be resold, which they cannot, but the analogy holds. So many times that the earpieces were a different brand than the chest piece, and the tubing had been replaced twice, and the whole instrument looked like a piece of equipment that had been somewhere and done something, and was still going. She signed in at the travel nurse desk. She received her badge. Her badge said Marin, just the first name, the way travel badges always read, a small typographic signal to the permanent staff that this person is temporary, provisional, less than fully committed to the institution. She did not appear to notice. She was 34. She looked like someone who had been 34 for a while. Not older, exactly, but settled into her age in a way that younger nurses were not. She moved through the unit on her first orientation shift with the quiet efficiency of someone for whom new environments are not disorienting. She noted the location of the crash carts. She noted the defibrillator model and its charge sequence. She noted the telemetry monitor layout and the alarm threshold settings. She did not write any of this down. She was good with patience. Exceptionally good. She had a way of entering a room that did not startle anyone awake. A way of explaining procedures that made frightened people feel that the procedure was the most ordinary thing in the world. A way of reading a patient's face for the information their chart had not yet caught up with. The permanent staff noticed she was competent the way you notice the weather. As background fact, unremarkable, requiring no comment. Dr. Elliot Graves noticed her on day 3. Not favorably. Dr. Graves had run the cardiology department at this hospital for 11 years. Before that, he had trained at Cleveland Clinic. Before that, he had gone to medical school at a place whose name he worked into conversations with the ease of someone who has been doing it for so long they no longer register as effort. He was 58. His hair was silver and well-managed. His white coat was pressed. He had a parking spot with his name on it in the covered structure, and there was a wing of the Cardiac Rehabilitation Center that bore his name on a brass plaque, and the brass plaque was visible from the main corridor, and Graves had arranged it that way. He had a policy about travel nurses. The policy was not written anywhere official. It did not need to be. It was communicated in the way institutional power communicates most of its real rules. Through tone, through body language, through the specific quality of attention that a senior physician either extends or withholds in a clinical setting. The policy was this: travel nurses are support staff. They perform tasks. They do not formulate clinical opinions. They do not initiate conversations with attending physicians. They do not flag concerns through channels that bypass the permanent charge nurse. They do not, under any circumstances, position themselves as participants in the clinical decision-making process. He had communicated this policy to 3 travel nurses in the past year. 2 of them had requested reassignment within a week. The third had lasted the full contract and had never once spoken to him directly, which Graves considered an optimal outcome. Marin was the 4th. He became aware of her on a Wednesday morning during rounds. He was reviewing the chart of a post-cardiac catheterization patient in Base 6, a 63-year-old woman named Dolores who had undergone a left main stenting procedure the previous afternoon, when he noticed a nursing note from the overnight shift that flagged a QTC interval of 478 milliseconds on the morning ECG and recommended a cardiology review of the patient's current medication panel for QT prolonging agents. The note was precise. The note was correct in its methodology. The note cited the relevant guideline threshold. The note had been written at 0447 hours by a nurse whose name he did not recognize. He found a nurse at the medication card. "You flagged a QTC concern on my patient in Base 6, he said. Marin looked up. "Yes, sir." The morning ECG showed, I read the note. He did not raise his voice. He never raised his voice. "I want to be clear about something. When a travel nurse has a concern about one of my patients, that concern goes to the charge nurse. The charge nurse brings it to the resident. The resident brings it to me. That is the pathway. That pathway exists for a reason. Do you understand?" "Yes," Marin said. "The QTC is within acceptable post-procedural variance." He looked at her for a moment. "Travel nurse pattern recognition," he said, "is not the same thing as clinical judgment. I want you to keep that distinction in mind." He walked away. Marin looked at the medication card. She looked at the ECG strip she had folded into the pocket of her scrub top. She put the ECG strip back in her pocket and went back to work. 3 days later, Dolores in Bay 6 developed a run of torsades de pointes, a specific and dangerous ventricular arrhythmia that is a known complication of QTC prolongation and required emergency cardioversion. She survived. The cardiology fellow who managed the emergency ordered a full medication review. The QT prolonging agent was identified and discontinued. Nobody connected this to the nursing note from 4 days prior, or if they did not say, so where Graves could hear it. Marin did not say anything about it either. The second incident happened on a Friday afternoon, 3 weeks in her contract. A patient in Bay 9, a 71-year-old man named Frank, 2 days post-valve replacement, began showing signs of deterioration that his monitors were not yet catching. His pressure was trending down in increments small enough to fall within normal variation. His urine output was slowing. His skin, when Marin placed her hand on his forearm to reposition his fore, was cooler than it should have been for a man whose temperature read normal. She positioned herself at the head of his bed, not because she was asked, because something in the accumulated data of the last 2 hours, none of it individually alarming, all of it collectively wrong, told her that Frank was about to go somewhere bad, and she wanted to be where the airway was when it happened. Graves came in on afternoon rounds with 2 residents and a medical student. He saw Marin at the head of the bed. He looked at her badge. He looked at the position she had taken, a position that, in any operating room or trauma bay or intensive care environment with a functioning hierarchy, signals clinical authority. He looked at his residents. "Could someone redirect our travel nurse to her appropriate station?" he said. "Not to Marin, to the room." One of the residents, a second-year named Park, who had the look of someone who had witnessed this before and had not yet decided what to do about it, stepped forward. "This way," Park said quietly, gesturing toward the corner of the room. Marin moved. She did not argue. She did not explain. She went to the corner of the room and she watched. Graves reviewed Frank's chart. He adjusted one medication. He moved on. 40 minutes later, Frank coded. Marin was first to the bed. She had not left the room. The code was managed. Frank was stabilized and transferred to the cardiac surgery suite for an emergency re-exploration. There was a slow bleed at the anastomosis site that the monitors had been missing for hours. Frank survived. Graves, reviewing the timeline later, would note that the nursing response time had been unusually fast. He did not investigate why. I want to tell you about the life that preceded the travel badge and the rolling duffel and the stethoscope that looked like it had been to war. It had been to war. Marin had enlisted at 19. She had gone to Fort Sam Houston for combat medic training, 68 whiskey, and had been good enough at the work and had been in the right place at the right time with the right scores to be selected for additional training that she is not going to describe in detail here. What she will tell you is that she spent 6 years operating in environments that ranged from uncomfortable to actively hostile, and that her specific function in those environments was to keep people alive in conditions where the standard of care was whatever she could do with what she had before the next thing happened. She was attached, at various points, to units whose names are not available in any public directory. She was called Ironside. The call sign came from a warrant officer named Decker, who had watched her manage a trauma in a vehicle that was still moving under fire, and had said afterward, with a particular economy of expression that defines people who have been in those situations, "You don't move." He meant it as the highest possible compliment. It stuck. She left the Army at 26. She finished her nursing degree. She became a travel nurse because travel nursing meant she never had to stay long enough for anyone to ask questions, and she had spent enough of her life in situations where questions were dangerous that the habit of avoiding them had become structural. She kept her sleeves at a standard length. She kept her past in a place that required active excavation to find. She did her job, and she did it well, and she moved on when the contract ended. She did not expect Texas to be different. Then the weather changed, and a helicopter went down 40 miles out, and everything that Marin had spent 3 years trying to keep behind her caught up with her in a private cardiac hospital in Houston. The call came through at 1847 hours. Marin was in the middle of a medication pass when the overhead speaker activated. Not the standard paging system, the emergency frequency, the one that sounded like a different kind of silence before it spoke. "Attention, all clinical staff. We have an incoming trauma diversion. MH-60 crew, 2 personnel, 1 critical, ETA 11 minutes. Cardiac trauma protocol activated. All available senior clinical staff report to the trauma receiving area." The unit went still for exactly 1 second. Then it erupted. Marin finished capping her syringe. She understood several things simultaneously. She understood that this hospital had no trauma protocol in any functional sense. It had a document called a trauma protocol that had been written 4 years ago and reviewed by no one with actual trauma experience and had never been activated in a live event. She understood that the incoming aircraft was a military helicopter. The MH-60 designation was not a civilian medevac configuration. She understood that 11 minutes was not a lot of time to prepare a cardiac ICU for a trauma reception. She walked to the trauma receiving area. Dr. Graves was already there. He was in the center of the room with 2 residents and the charge nurse and a respiratory therapist who looked like she was hoping someone would tell her specifically what to do. Graves was holding a printed copy of the trauma protocol document. He was reading from it in the measured, authoritative cadence of a man who has never been uncertain in public. "We'll receive in Bay 1. I want 2 large-bore IVs established on arrival. Respiratory, I want a ventilator at bedside. Nursing, I want a full trauma panel ordered. Cross-match for 4 units. Let's be ready." The residents were writing things down. Marin stood at the edge of the room. Graves looked up. He saw her. Something moved across his face, not quite irritation, not quite dismissal. A category assignment. Travel nurse. Peripheral. Available for task assignment if needed. "You." He pointed at her. "Bay 1 setup. For supplies, trauma kit, get the ultrasound to the bedside." "Yes, sir," Marin said. She began moving. She set up Bay 1. She also, while setting up Bay 1, repositioned the crash cart to the left side of the bed rather than the right, changed the ventilator settings from the default to a configuration she had used before in trauma contexts, laid out a needle decompression kit alongside the standard supplies, and placed a thoracotomy tray on the lower shelf of the equipment cart, covered but accessible. Nobody noticed. Nobody was watching her. They were watching Graves. The helicopter landed on the roof at 1858 hours. Marin heard it before the monitors registered the vibration. She heard the way she always heard it, not as sound but as pressure, as a frequency that traveled through the building's bones and into her own. She set down the last piece of equipment, and she stood very still for a moment. Then she heard the rotors change pitch, the specific deceleration of a bird going from flight to hover to set, and she heard the distant percussion of boots on a rooftop, and she thought, "Here we go." They brought him down on a sked stretcher, the flexible rescue type, not a standard litter, which told Marin two things immediately. They had extricated him from a confined space, and whoever packaged him for transport had done it fast and in the dark. The co-pilot's name was Weston, CW3. He was 31. He was in flight suit, partially cut away at the chest. His helmet was still on. Someone had made the right call not to remove it without imaging, and his face, what was visible of it, was the color of old ash. He had a cervical collar applied. He had a tourniquet on his right arm, high and tight. He had a chest seal on the left side of his thorax, the kind with the flutter valve, which meant someone on scene had identified a penetrating chest injury and had managed it in the field. He was breathing, barely. The flight crew set him on Bay 1. There were 3 of them, 2 in flight suits, 1 in tactical gear, the latter of whom stepped back immediately and positioned himself near the door with his arms crossed and his eyes on Weston. Marin clocked him. Unit medic, not flight crew. He had come along to make sure his pilot survived the handoff. Graves moved to the head of the bed. "All right," he said. "Let's get that helmet off and get a look at it." "Don't move the helmet." Marin set it from the right side of the bed, where she was already checking the chest seal. The room went quiet. Graves turned. He looked at her. The specific look of a man who has just heard a travel nurse countermand an instruction in front of witnesses. "Excuse me." He has a mechanism for cervical injury. The helmet is the only rigid stabilization on his neck right now. If you remove it before imaging, you risk converting an incomplete injury to a complete one. She did not look at Graves while she said it. She was looking at Weston's chest, at the flutter valve, at the way the chest seal was moving, or rather, at the way it was not moving correctly. His chest seal is failing. The flutter valve is occluded. He's retensioning. She reached for the needle decompression kit she had placed on the cart. "You do not have authority to," Graves began. "His trachea is deviating." She said it the way you say a fact, not the way you argue, the way you inform. "Left side tension pneumothorax. He has approximately 90 seconds before this becomes a cardiac arrest." She looked up. She looked at Graves. "You can stop me," she said, "or you can let me work." The unit medic near the door unfolded his arms. Graves did not move. Marin found the second intercostal space on the left side of Weston's chest, mid-clavicular line. She pressed 2 fingers down, confirmed the landmarks, uncapped the needle. "Hold his shoulders," she said to the nearest resident. "Don't let him move." The resident, Park, the second year, moved to the bed and held Weston's shoulders. Marin drove the needle home. The hiss was immediate and significant. The sound of pressure that has been building in a closed space finally finding an exit. Weston's oxygen saturation, which had been reading 71 on the monitor and dropping, stopped dropping. 71, said the respiratory therapist, watching the screen. "It'll climb," Marin said. She was already reaching for the chest tube tray. 74, said the respiratory therapist. Marin looked at Park. "I need you to hold the tube when I hand it to you. Sterile. Don't let it touch anything." "Can you do that?" "Yes," said Park. 78, said the respiratory therapist. Her voice had changed. The hoping someone would tell her quality was gone. She was reading numbers now. She was part of the team. Marin found the 5th intercostal space. She looked at Weston. He was not conscious, but she said it anyway. "This is going to hurt." "I'm sorry. Stay with me." She made the incision. The chest tube was in place at 1911 hours, 13 minutes after Weston arrived. His O2 sat was 91 and climbing. His blood pressure, which had been absent on arrival, was 62/40 and moving in the right direction. The hemorrhage from his right arm was controlled by the tourniquet. His cervical spine had not been moved. Marin stepped back from the bed. Her gloves were dark. Her forearms were dark. She stripped the gloves and reached for the paper towels at the sink, and in the motion of stripping the gloves and reaching for the towels, she registered, in the peripheral awareness that never fully turns off, that Dr. Elliot Graves had not moved from his position near the head of the bed in the last 13 minutes. He had not assisted. He had not hindered. He had stood at the head of the bed, and he had watched. She did not know what that cost him. She did not think about it. He needs imaging before transport, she said to the room. Chest, C-spine, pelvis. His abdomen is soft, but I want a fast exam before you move him. She looked at the respiratory therapist. Keep him on the vent settings I loaded. Don't adjust unless his SATs drop below 88. Okay, said the respiratory therapist. Park. Marin looked at the resident. Document the tube placement. Time, position, patient response. Get the fellow on the phone. Got it, said Park. She walked to the sink. She turned on the water. She scrubbed. The unit medic was beside her before she heard him move. That was good work, he said. He had a good package on him. She was still scrubbing. The field seal bought him the time. That was ours, the medic said. There was something in his voice, recognition, or the beginning of it. Who trained you? Marin turned off the water. She dried her hands. She looked at him once, a brief, flat look that said everything and confirmed nothing. I'm just a travel nurse, she said. She walked back to her charting station. Weston was transferred to the surgical suite at 20:34 hours. He was alive. His cervical spine was intact. The chest tube was draining appropriately. The arm tourniquet had been converted to a vascular surgery consult. The unit settled. Graves disappeared into his office. Marin saw the light under the door. She sat at her charting station and she wrote her notes. She wrote them the way she always wrote them. Precise, clinical, complete. Timestamps. Intervention sequence. Patient response to each intervention. She wrote them as though she expected them to be read by someone who would want to know exactly what happened and in what order and why. She was 3/4 finished when the elevator opened. She heard the flight's suit before she saw him. The specific rustle of Nomex, the soft percussion of flight boots on ICU flooring. The warrant officer was CW4. She did not recognize his face, but she recognized his bearing, the specific physical economy of someone from that world, from those units, from emissions that do not have letterheads. He walked past the charge desk. He walked past the unit secretary. He walked past Dr. Elliot Graves, who had emerged from his office at the sound of the elevator and was standing near the nurse's station with his tablet and his pressed white coat and his name on a plaque down the hall. The warrant officer did not look at Graves. He walked to Marin's charting station. He reached into the chest pocket of his flight suit. He produced a coin. The 160th Special Operations Aviation Regiment, the Night Stalkers, a unit whose motto is Night Stalkers Don't Quit, and whose reputation requires no elaboration to anyone who has operated in the same spaces they operate in. He sat on the desk in front of her. She looked at it. She looked at him. Fire inside, he said. She picked up the coin. She turned it once in her fingers, not with sentiment, exactly, but with the particular attention you give to something that carries weight beyond its physical mass. She set it back down next to her keyboard. She went back to her charting. The warrant officer nodded once. He turned and walked back to the elevator. The doors closed. In the silence that followed, the ICU monitors continued their low, arrhythmic chorus. The overnight lights held at their dimmed setting. The respiratory therapist at the far end of the unit was checking ventilator settings, her back to the nursing station. Dr. Elliot Graves stood near the nurse's station with his tablet in his hand. The screen had timed out. He was looking at the coin on the desk next to Marin's keyboard. He was looking at the way she had gone back to her charting, as though the last 4 hours had been an ordinary shift. He was looking at the travel badge clipped to her scrub top, the badge that said just Marin, just the first name, the typographic signal that this person is temporary, provisional, less than fully committed to the institution. He opened his mouth. He closed it. He looked at the tablet in his hand as though he had forgotten what it was for. Park, the second-year resident, was at the medication station 10 feet away, writing notes. He had watched the warrant officer place the coin. He had heard the call sign. He was young enough that his face had not yet learned to hide what it was thinking, and what it was thinking as he looked at Graves, and then at Marin, and then back at Graves, was something that would take him years to fully articulate, but that he understood in that moment with complete clarity. He went back to his notes. Marin finished her charting at 0217 hours. She stood, stretched her right shoulder, the one that had a piece of shrapnel rearranging its geometry on a rotation she was not going to specify, and picked up the coin from the desk. She held it for a moment. Then she put it in the pocket of her scrub top, next to the ECG strip from base 6 that she had never thrown away, and she went to check on her patients. Weston was extubated on day 3. His cervical spine was cleared on day 2. No injury. The chest tube came out on day 4. The vascular surgery consult on his arm resulted in a repair that the attending described as textbook. On day 5, he was alert enough to ask the ICU nurse on duty who had placed his chest tube on arrival. The nurse, not Marin, she was off that day, said she didn't know exactly, but it had been the travel nurse on nights. Weston asked for a name. Nobody knew her last name. Her badge only had the first name. That was how travel badges worked. He asked what her first name was. Marin, the nurse said. Weston looked at the ceiling for a moment. Ironside, he said quietly. Not a question. The nurse didn't know what that meant. She wrote in her notes anyway, under the heading of patient statements, because you write down what patients say and you let the physicians figure out what it means. Dr. Elliot Graves read the note during afternoon rounds. He stood at the nursing station for a long time after that, reading the note on Weston's chart. Then he set the tablet down on the counter, carefully the way you set something down when your hands are not entirely steady, and he walked to the window at the end of the corridor, and he looked out at the Houston skyline and the parking structure with his name on the covered spot and the early afternoon light coming off the glass buildings downtown. He stood there for a while. Nobody bothered him. People had learned, over 11 years, to read when Graves did not want to be approached. Today, he radiated something different from his usual inapproachability. Today, he radiated the particular stillness of a man who is doing arithmetic and not liking the answer. He went back to rounds. He did not call Marin into his office. He did not apologize, because men like Graves do not apologize, or at least not yet, and maybe not ever. But the word furniture did not come out of his mouth for the remainder of her contract. And when she flagged an abnormal ab value 2 weeks later, he did not reroute the concern through the charge nurse. He came to her directly. He asked her what she was seeing. She told him. He ordered the test she suggested. She was right. He did not say so out loud. But he ordered the test, and the test came back the way she said it would, and he stood at the nursing station reading the result for a long time. Marin's contract ended 6 weeks later. She signed out at 0700 hours on a Thursday, returned her badge to the travel desk, and walked to her car in the general parking lot. Not the covered structure, never the covered structure, with her rolling duffel and her backpack and her stethoscope. The 160th SOAR coin was in the front pocket of her jeans. She had kept it there since the night the warrant officer placed it on her desk. Some things you carry in a case. Some things you carry in your pocket, close to your hand, where you can feel the weight of them when the day gets long. She drove north on I-10 until the Houston skyline disappeared in her rearview mirror, and then she drove a little further, and then she turned on the radio, and then she let the road do what roads do when you need the distance. She did not know where the next contract would take her. It didn't matter. She would find the crash cart. She would note the defibrillator model. She would keep her sleeves at standard length and her past in the place that required excavation. And if the world needed Ironside again, if the rotors came through the ceiling and the elevator opened and someone walked past the charge desk without looking at it, she would be right where she always was. At the charting station, in the corner bay, doing the work, just a travel nurse. If Marin's story found you, if you have ever been written off by someone who didn't take the time to find out what they were writing off, tell me in the comments. Have you ever watched someone get dismissed and known with certainty they were the most capable person in the room? Because that's what this story is really asking. Not about hospitals, not about rank, about the cost of arrogance in the moments when competence is the only thing standing between someone and the worst outcome. Subscribe if you want more stories like this. They're here every week. The quiet ones. The ones who don't explain themselves. The ones who just work.